Good afternoon, everybody, and welcome to what is now the 11th UCD COVID series. My name is Fiona McNicholas, a child psychiatrist at UCD, and I'm co-hosting with my colleague Dr. Blonid Gavin and Mr. Paul Harkins, along with the College of Psychiatrists in Ireland. And thank you all once again for coming. Our topic today is that of suicide during COVID. And this is the first time we're having two speakers speak. So I might just start off by introducing our first speaker, who is probably well known to many of you, and that's Dr. Pat Devitt. Pat, as you know, is an adult psychiatrist, but who has previously worked as the Inspector of Mental Health Services in Ireland. And Pat certainly has presented and published and is recognised widely for his contribution to the topic of suicide. And Pat, we would love if you would kick off from the perspective maybe of, setting it in an Irish context before moving to our international speaker.
So I'll go ahead then, Fiona. Thank you very much for your introduction. I'm just going to try and share the screen. I think it should come up now.
Perfect.
There it is. I think, does everybody, can you see the screen?
Yes, thank you.
Yeah, so thank you for your introduction. And this is just a very brief introduction to set the scene for David's more extensive talk afterwards. I'm just going to look at a few facts and figures to outline what is the situation with respect to suicide in Ireland and what we do at dealing with suicidal behaviour in psychiatry and otherwise as a matter of policy. In preparation for this very brief talk, very brief gallop actually, I rummaged through the internet and found some interesting sites, and hopefully you will find them interesting as well. I'm also going to mention one or two papers. So here's an overview. I'm going to just talk for about 1 or 2 minutes about my own reflections. That's the National Office for Suicide Prevention, with whom David is familiar, I think, at least from the report. Then there's also the National Suicide Research Foundation, which he's probably also familiar with. We have the Irish Association of Suicidology, the National Clinical Programme, and then there's a paper, a very interesting paper on from St. John of God's area on referrals for suicidal crisis. And then no presentation will be complete in Ireland without mentioning Brendan Kelly's book, Hearing Voices. In fact, he gets very annoyed when we don't mention it in presentations. So I'll proceed first of all on the personal reflections. I trained in Ireland in the 1980s, and at that time, as you will see later on, suicide actually was criminal. It was a felony to kill yourself and it was a misdemeanor to attempt it. So when we were taught about suicide and all the various epidemiological associations, and it was part of our exams. But in practice, I was in St. Edith's and St. Brendan's. It didn't seem to affect us too much. We knew about people running off in St. Edith's out in Portrane into the water, and we heard about hangings and so on, but it didn't really impact too much on our practice. As I say, it was criminal until 1993. Then I worked in the United States in the 1990s, and I was sort of shocked there that suicide had become a sort of form of currency, where doctors who were looking for payment permission from the insurance companies were playing the suicide card to get their permission. And also patients were playing the suicide card, it seemed like, to get into hospital. We used to joke that the patients pretended to be sick and the doctors pretended to treat them. But the suicide was part of that currency. And then when I returned to Ireland then in 2000, I was sort of shocked again that it had changed so much from what I had remembered. And now it seemed that everybody was obsessed with suicide, the media were full of it, everybody was talking about it. And then in practice too, it had become similar to the way it was in the States, that people were using, or if anyone mentioned that they were suicidal, there was an automatic semi-panic, and there was almost an obsession. And we wondered if the tail was wagging the dog. But these are my personal reflections. So in my rummages through the internet, I found the annual report, the latest of the National Office for Suicide Prevention. And their report refers to the figures for 2018. Just to give you an idea of the core work, it's working towards a vision of an Ireland where fewer lives are lost through suicide and where communities and individuals are empowered to improve their mental health and well-being, which is fairly generic. They have a budget of €12 million. Here are the figures. 2018, the overall rate was 7.2 per 100,000, and there's a male to female ratio of approximately, in this case, about 4 to 1, which is, I think that's fairly standard. And looking back at the figures down to 2008, when our recession began, it was 11.8 per 100,000, went up to 12.8, but didn't really get any higher all the way up. And of course, the difficulty with suicide figures is actually what is a suicide, and then what's included and what's not included. And you can see the difficulties there, including late registration, excluding late registration, and then provisional. So we're always operating behind. And I'm sure David will have much more to say about that. And in terms of comparisons, we're not too bad. We have the 11th lowest rate in 34 countries. But however, and Fiona would be interested in this, and this is well known, that among the 15 to 19-year-olds, we have the 9th highest rate. So we're relatively, we have a higher rate for the younger people in Ireland, but we're not too bad. We're right in the middle. I would say maybe better than most in terms of our suicide rates. As you know, there's a very wide range of rates around the world, going from very, very high, and it's high in the Scandinavian northern countries, and it seems to be better in the Mediterranean countries, but that's an epidemiological matter. Also, in this report are figures for self-harm, and you can see the rate there is the age standardized rate of individuals presented to hospital in the public around following self-harm in 2018 was 210 per 100,000. That's presenting to hospital. Now, presumably there are self-harms that don't present to hospital. So that's 210, and say 10 suicides per 100,000. So it's a 20-fold rate. So self-harm occurs at 20 times the frequency of actual suicide. And probably more will be spoken about that. Those who self-harm have a higher rate of suicide, but don't necessarily die by suicide. And those who die by suicide haven't necessarily self-harmed in advance. And you can see that it's been fairly consistent from 2002 all the way down to 2018. And here's the age range of those who die by who self-harm. And as we know, it's younger. And it's especially in the younger age group, it's more female than male. So we know all that, but that's just to set the scene. Now, the financial overview, I thought that was interesting. It's 12 million of a budget, and these are, most of the 7 million goes to grants to agencies. So the national office is heavily involved in supporting community agencies. And I counted 33 of these agencies to which they give grants. And you can see that the biggest recipient is the Pieta House. Now, I'm not sure about other countries. Maybe David can enlighten us on this, but Pieta House has a very high profile and excellent marketing, and they run a lot of fundraisers, and they're by far the highest recipient of funding from the national office. And I also, when I was rummaging, I thought that it might be interesting to look at their first report in 2005. And the first report showed an increase in the male suicide. It was from 1980 up to 2003. Now, I'm not sure, we often say that suicide increased dramatically during our recession, but looking at those rates here, it seems that they were higher earlier. And of course, the female and male difference is obvious again here. I just want to mention a few things that we have here in Ireland. We have the Irish Association of Suicidology, which was founded by Dr. Michael Kelleher from Cork and Dr. John Connolly from Mayo, and also Dan Neville, the TD, who was heavily involved in the whole issue of suicide and was advocating, when I came back from the States, very much so politically. And then there's the foundation of the setting up, establishment of the National Suicide Research Foundation. I think that was around 1994, again by Michael Kelleher. It started in Cork and it's still in Cork, and it does a lot of very good work and publishes a lot of papers. And here's one of the most important papers that was published by this group, the impact of this economic recession and subsequent austerity on suicide and self-harm in Ireland. And their conclusions were that 5 years of economic recession and austerity in Ireland have had a significant negative impact on rates of suicide in men and on self-harm in both sexes. And it seems it was men that were predominantly affected with respect to suicide rates. by the recession. And I think it's well known that economic recessions do cause an increase in the suicide rate. And interestingly enough, in those countries where there's a very good safety net, the rate increase doesn't seem to be as bad. And this is a service that was set up by our HSE, a suicide crisis assessment nurse attached to general practices to help GPs deal with suicidal crises or people stating that they were suicidal or dealing with suicidal behaviour, where there was a pretty prompt assessment by a nurse and referral if necessary, or dealing with the situation if necessary. And then the National Clinical Programme was set up by the HSE around 2000 and I think it was 2012, I saw it there earlier. And that programme involves having clinical nurse specialists attached to emergency departments where people presenting with self-harm or with suicidal behaviour or suicidal intent are assessed and allocated to appropriate treatment. Now here's an interesting paper I read about. It's by Larkin Feeney and others, published in the Irish Journal of Psychological Medicine, and he's talking about referrals to a mental health service. And there was a 20-fold increase in the number of new referrals between 1983 and 2013. And over that 30 years, there was a significant decrease in the proportion of referrals expressing concern about psychosis, but an increase in the proportion that were deemed urgent and which were concerned with suicidal risk. And the referrals were longer and more likely to contain requests for psychotherapy. So in other words, what I had noticed, what I thought I had noticed myself in the 2000s and afterwards, it seemed to be borne out there that there was an increasing worry, concern about suicidal risk, and that was impacting on the workload of a community mental health service. I mentioned that Brendan Kelly would get annoyed if I didn't mention his book. It's a great book actually, and has a very valuable few pages on suicide in Ireland. It's just 3 pages. It looks like he has posted it on a lamppost by the curve on it, but I don't believe he has. Maybe he has done it, but I copied this, and the book had, because it was so unused, I suppose, the book was curved. But it makes a nice picture, and he gives some very good information in a very condensed, succinct way. And then one of the nuggets in that subchapter is the following. In 2016, it was estimated that there were up to 300 different groups providing support for those at risk. So in other words, almost every village in Ireland had their own suicide prevention group. And they didn't all get funding. Only 10% of them got funding from the National Office for Suicide Prevention, but a lot of them would have done local fundraising. So that's just an idea. I presume these 300 are still operating. So here's a roundup of what I've been talking about. So our suicide rate is not particularly high by international standards. The rate for young people, though, especially male, is relatively higher. As a nation, we're highly aware and frightened by suicide. We're not unique in that. But that's evidenced by all the multiple interventions we have at state level, at state-aided voluntary level, and also with charitably funded, at charity-funded voluntary level. And here's a question I have, just to put the cat among the pigeons. Would funding be better employed improving generic primary and secondary care mental health services and implementing safety measures, for example, the paracetamol packaging or guarding dangerous iconic type locations? So I'll finish at that and hand you over back to Fiona. Thank you very much. Thank you, Pat, for setting the scene so well. I guess it really highlights the fact that suicide and self-harm is a very emotive event, and you know, so many villages and local people are so passionate about setting up services. But I do think that's very important by way of funding. And you might even argue, given that the rates of self-harm in youth have increased exponentially, and I'm sure David may talk a little bit more to it, that again, investing more in trying to change that trajectory as a coping mechanism would be equally important to consider. But I'm delighted to welcome our international speaker, Professor David Gunnell. And again, just like Pat, many of you will be aware of David's research. He's an award-winning researcher and scientist and lead investigator, and really has published very, very widely in the area of suicide. He's an epidemiologist in the University of Bristol,
And I think you're trying to have some real live data, or to have, you know, that's one of the benefits of having such experts involved in service delivery. So David, over to you, and thank you again.
Thanks very much, Fiona. It's a real pleasure to be talking to you all today. What turns out to be a lovely sunny day here in Bristol in the UK. I think the weather's not so good for you over in Ireland from when I glanced at the forecast, so I'm sorry about that. And it's great to hear from Patrick about all the initiatives that happen in and are going on in Ireland. I sort of look in awe at the amount of funding that, and you'd probably all want more, I'm sure, but I look from England in awe at the amount of funding that you have, and some of the initiatives you've got, some of the national initiatives, the National Clinical Programme, your nationwide self-harm register. So yeah, great work, and well done to all of those in the National Office. I've got very happy memories of my time in Ireland. The very first, I think, plenary talk I gave was about 25 years ago over in Castle Bar at an Irish Association of Suicidology, and I visit Cork from time to time, and the group over there. So yeah, and I hope everyone's keeping well. These are tough times for everyone, aren't they? And apologies, the focus of my talk is on risk of suicide and the COVID-19 pandemic. I'm going to keep away from some of the generic issues that Patrick was talking about now, but just, you know, echo his concerns. You know, some of our big concerns at the moment globally and in high-income countries are rises in suicide amongst young people. But who isn't at the moment thinking about COVID-19, the COVID-19 pandemic, and its impact on mental health and possible suicide risks? So that's what I'm going to focus on, talk about the sort of concerns, talk about what we know to date about the impact of the pandemic on suicide and suicidal behaviour internationally. And the answer is not too much just yet. And then talk a little bit about prevention and research. At the top right of my screen there, I've got the logo of the International COVID Suicide Prevention Research Collaboration. It's a bit of a mouthful, and it's great to have within this international group. There are about 55 of us involved. Ella Aronsman from Ireland, I'm sure many of you are familiar with. And we've come together to think about how the global suicide prevention community can respond to this issue. So, as I said, just a reminder, if we need reminding, of the size of the issue with COVID-19. The last 7 months has been an unprecedented time in, I think, many, if not all, of our lives. The last time I looked at the figures, over 677,000 people had died from COVID-19, and around the world 17 million people had been infected. And there has been a lot of speculation in the news reporting. In suicide prevention, we're really concerned about the possible impact of some aspects of news reporting on suicide risk. And there have been several rather dramatic headlines raising concerns about the impact of COVID-19 on suicide rates. This one in the bottom right of your screen there is just an example of perhaps one of the most extreme ones. It's interesting, a follow-up story on the same website a couple of days later actually almost retracted that story. And sometimes actually the issue of suicide risk and mental health risk has become politicised. People who've got particular agendas around aspects of the public health protection measures have preferred particular stories. But I think in the research and prevention community, what we really need to know, I think, is what will be the impact of COVID-19 on population mental health and suicide rates beyond the newspaper headlines. And perhaps particularly, what can us in the suicide prevention community do to reduce that impact? So those are some of the issues I'm going to be talking about. Here's an example, a more widespread example of some of that reporting I just referred to from around the world. You know, this is an illness that's affecting people in top left, the States, middle of the slide there, stories of a rise in suicide in Nepal. In fact, the stories and the early data that has been reported suggest there may have been more suicide deaths in Nepal than there have been deaths from the virus itself. Well, that certainly isn't the case. on a global basis. But there's actually very little data as yet, and I'll go through some of what we know about the impact. Of course, the first thing we do when presented with a public health emergency is look back and see, well, what do we know from our past experiences? What does the literature tell us about the impact of previous pandemics on suicide rates and mental health? And perhaps the paper that's most often cited in relation to global infectious disease pandemics is Ira Wasserman's piece looking at the impact of the Spanish flu pandemic on suicide rates in the United States around the time of the pandemic. This slide here shows rates of overall mortality, that's the kind of line without the crosses, and rates of suicide mortality, that's the line with the crosses on it, between 1910 and 1920. It's important to bear in mind that whilst the two lines track each other fairly closely, there's a 100-fold difference in the rates. The rates of overall mortality are rates per 10,000, that's the number of deaths per 10,000 people in the population, whereas the suicide rates are rates per million population. So the scale has changed somewhat, so you can actually see the extent to which the lines track. What's most apparent from the slide, of course, is that peak in mortality in the end of 1918 and a second peak in 1919 and 1920. That's all-cause mortality, and it's largely due to a rise in deaths from the Spanish flu pandemic. So 1918, 1920, Spanish flu pandemic caused many tens of thousands of deaths in the United States. If you then look at when those peaks in overall mortality occurred, which are the markers of when the flu pandemic occurred, you see very little evidence of a change in suicide rates. In fact, in the years leading up to the pandemic, suicide rates, if anything, were declining in the United States, and very little evidence, certainly no evidence of a marked rise in suicide rates. However, with careful statistical analysis, taking account of seasonal fluctuations in suicide, taking account of the impact of the First World War, which ended around then, alcohol regulations in the States, which changed over this period, and newspaper reporting, there is evidence of a slight statistically detectable rise in suicides around the time of the pandemic. Nothing major. If it was major, you would see it on this slide, but there's some statistical evidence. The other source of evidence that people are citing when they talk and speculate about the impact of the pandemic is the impact of the 2003 SARS epidemic in Hong Kong and the Far East. And Paul Yip and colleagues in Hong Kong looked at this. And whilst they didn't find any evidence of a major rise in suicide, there was some evidence that suicide rates amongst older people increased for a short period of time. And that speaks to, I think, present day concerns about the isolating effects of physical distancing from people having to stay at home. But that was short-lived, and there was no statistical analysis of those data. So actually, we haven't got too much to go on in terms of informing us about what might happen with the current pandemic. I think the other thing, and I've talked about the difference in scale between overall mortality and suicide mortality in that last slide, I think we need to remind ourselves of the differences in numbers of COVID deaths and suicide deaths. In the UK, for example, in 2018, for the 12 months of 2018, there were 6,500 suicide deaths. But just in the 5 months of the pandemic, there have been 46,000 COVID-19 deaths. And Patrick's just flagged up some figures for suicide deaths in Ireland, somewhere between 380 and 540 in any given year over the last decade or so. And again, that's way fewer than the COVID-19 deaths, again, in this period, March to July 2020. So we need to put things in context. And when we think about our public health measures, we need to bear in mind that whilst, were suicide rates to go up by a small amount, that may be small compared to the amount by which overall mortality might rise if insufficient measures are taken to protect populations from COVID-19. But that situation may differ from country to country. I've already flagged up Nepal, where there's some evidence that actual deaths from the virus may be outnumbered by deaths from suicide. So we need to think about context as well. So in response to all this uncertainty and global concern, in around April time, we established what we call the International COVID-19 Suicide Prevention Research Collaboration, ICSPRC. And we wrote a commentary in Lancet Psychiatry, it was published in April, outlining what the concerns of a group of international suicide prevention experts were about the pandemic. And I've given the web link at the bottom right of the slide there. Top right shows the list of countries affected. We've tried as far as possible to engage within our thinking people from high and low income countries. I've already mentioned Ella Aronsman from Ireland is engaged with this. We have several other people from Europe, but we also have representatives from South America, India, and elsewhere to inform our thinking. I don't expect you to read the figure in the on the right-hand side of the slide there, but this is an expanded version, which too may be difficult for you to see, but it outlines what we felt were some of the most important considerations. So on the left-hand side of the figure, we talk about selective and indicated interventions to help mitigate the impact of the virus and the public health measures. So thinking about issues raised by the public health measures to control the virus, such as the reduction in the amount of face-to-face consultation that is likely to occur, the challenges doing risk assessments, not in a face-to-face situation, the stigma faced by people recovering from COVID-19, and some of the challenges faced by the charitable services who run helplines, keeping their services manned in a time of crisis. From a public health perspective, we were concerned about issues such as potential rises in domestic violence from people being locked in together with their potential abusers for a period of time, and domestic violence is emerging as an important risk factor for suicide. We were concerned about rises in alcohol misuse. We were concerned about the media reporting, which I've talked about already, given the evidence that some aspects of media reporting may lead to rises in suicide. And we were concerned about, I think particularly the longer term economic effects of the public health measures. So the declines in GDP, the rises in unemployment that may occur, and the very well-known association between rises in unemployment and rises in suicide rates. It's a rough rule of thumb. We know that a 1% rise in unemployment is associated with something like a 1% rise in suicide rates. At least that was the experience in the 2008 Great Recession when looked at internationally. What's important to remember with that, though, is that the impact of recession and unemployment and suicide rates varies from country to country, and that variation is largely influenced by the kind of social policy measures that countries have in place to support those who lose their work, the economic measures made to support people through times of difficulty. So an important part, I think, of the public health response to this crisis in terms of mitigating suicide is to ensure that policymakers are well aware of the people who are most vulnerable, perhaps to the economic consequences of the virus, and measures are put in place to help offset those. So for the next part of my talk, after setting the context a little bit, I'm just going to briefly go through the kind of data that's available to us that gives us early indications of the impact of the current pandemic on suicidal behaviour. Some of the first data I saw came from Japan, and I'm sorry, this is a horrible slide, and I'm sure if anyone's fluent in Japanese, I'd be grateful for a translation, but the simple translation of the slide is that the red line, so this slide shows monthly numbers of suicide deaths in Japan for 5 different years. 2020 is the red line at the bottom of the figure, and it shows suicide deaths in Japan from January, month 1, up until June, month 2. And suicide rates in Japan for 2019 are the dotted pink line just above that, again on a month-by-month basis. The black line I've drawn about a quarter of a way across the timeline is the time when measures were implemented in Japan to curb the spread of the virus. So things like travel restrictions, things like encouraging people to work at home, physical distancing, and so on and so forth. And these are early data, but quite reassuringly, I think, no evidence from Japan at this stage of a rise in suicides resulting from the physical distancing measures. Of course, there's a big concern about longer term effects should the economy decline long term as a result of the pandemic. So I hope my lack of fluency in Japanese helped to make that slide relatively clear to you, and I think a relatively reassuring message from that. Less reassuring is some work we've been doing in Bristol, where the National Child Mortality Database is run by some neonatology colleagues. This database charts suicides amongst children aged less than 18. It collects data more or less real time on deaths from any cause, accidents, cancer deaths amongst young people. And there's a statutory obligation for authorities to notify people within a couple of days of the occurrence of the death. Thankfully, child suicide deaths are relatively rare, maybe around 2 per week in England. So we were able, using this register, to look at the number of child suicide deaths in the period prior to and during that early phase of lockdown in England between the 23rd of March and 17th of May. And we found no statistical evidence from this of a rise in child suicides. Nevertheless, the risk ratio of the rate ratio of 1.41 indicates that the number of child suicides did increase. It's just we can't be statistically certain that that was a real effect rather than a chance fluctuation because of low numbers of deaths. So the confidence intervals around that rate ratio of 1.4 span from anything from a possible 20% reduction in rates up to a greater than 2-fold increase. And the p-value of 0.23 indicates that there's no statistical evidence for a rise, but a hint there. What we did find was that the proportion of deaths amongst those aged less than 15 was higher post-lockdown. And we found that amongst the pre compared to the post-lockdown deaths, there was no difference in the proportion of children who died who were in contact with social or psychiatric services. Around a third of the child suicide deaths were in contact with services. What we also found, and this is more of an incidental finding, was around a quarter of the child suicide deaths, both before and after lockdown, had autism or ADHD. And I think that's an emerging and a risk factor that's growingly acknowledged as being associated with suicide risk, but no increase in risk amongst those with those problems, but a significant proportion of children who died before and after lockdown had autism or ADHD. Now, these are data shared with me kindly by my colleague Keith Horton from Oxford, and a bit like your national register, but on a smaller scale, there are a couple of centres in England that record in real time hospital presentations for self-harm. And these data from Oxford and Derby have been collected during the period of the pandemic. The data aren't as thoroughly collected as previously, or the kind of depth of the data isn't as thorough as previously because the teams have not had access to people who self-harmed but didn't have a psychosocial assessment. They can record that the episode occurred, but they have less detailed information on those cases. And with these data, Keith Horton and colleagues are able to look at trends in self-harm amongst patients aged over than 18 in Oxford and Derby and under 18 in Oxford. And these show a decline. So focusing first of all on children, or sorry, those aged 18 and over, in the 3 months after lockdown, between March the 23rd and June the 14th, there was a 40% reduction in the weekly number of self-harm episodes compared to the earlier part of 2020, and a 40% reduction also compared to the same period in 2019. Now, it's important to make that kind of comparison because of seasonal fluctuations in incidence. The reduction was somewhat more marked in younger individuals, and there was a greater reduction in self-poisoning than self-injury. Now, of course, that doesn't mean necessarily that the overall incidence of self-harm has declined. These are hospital presentations, and we all know the levels of concern that may have prevented people who previously would have gone to hospital with an episode of self-harm from seeking such help during the time of COVID-19. But reductions in presentations. Looking at the under 18-year-olds, a very similar picture, nearly a 50% reduction in the period just after lockdown, and over a 30% reduction in episodes compared to the same period in 2019. So taking account of seasonal changes, taking account of time of the year, there appears to be a reduction in hospital presentations. I emphasise that, hospital presentations. There are similar data from Paris. These are data published very recently showing emergency psychiatric consultations in the 4 weeks before, in the first 4 weeks of lockdown compared to the same period in 2019. And total consultations declined by more than a half, and recorded suicide attempts declined by more than a half. And again, these are hospital presentations and assessments rather than necessarily actual episodes. If we want to get a handle on population levels of self-harm, taking out the impact of possible changes in help seeking from hospital services, the best way of doing that possibly is through survey information. And very early on in the pandemic, a group at the University College London, led by Daisy Fancourt, established a regular questionnaire survey, asking people on a weekly basis about whether they had self-harmed in the last week. It also asked an array of other questions about levels of depression using the PHQ-9, anxiety using GAD-7. And what this slide here shows from the 30th of March onwards, so remember this is the week after lockdown began in England, and I think it was the same sort of period in Ireland, the numbers or the percentage of people reporting self-harm in the previous week. So we go from the 30th of March up to the 13th of July. And I think you'll agree there's no real evidence of a rise in self-harm over this time period. Of course, the really important missing element of this is the pre-lockdown data. We haven't got that. That's a real challenge with this. My apologies for this slide, it's slightly busy. Top left shows the trends in self-harm. So it's the same data, but top left stratified by age. So if you look at different age groups, you can see whether there's any evidence of a trend that differs from that overall trend in the youngsters. The youngsters, 18 to 29-year-olds, those aged less than 18 weren't included in this survey. And no evidence of a differential rise in any of the three age groups. So 18 to 29-year-olds, the light blue, 30 to 59-year-olds, the middle line, and those aged 16 above, that bottom line there. So no obvious evidence of a trend. Bottom left looks at trends in self-harm by key worker status. The orange line are key workers. Again, no evidence of a trend in key workers compared to anyone else. And the top right slide there is first of all a reminder of the differences in self-harm rates according to socioeconomic position. The orange line is the trend in incidence over time amongst those from low-income households, and the bottom line is those in higher income households. So first of all, you see that the orange line is considerably higher than the blue line, reflecting what we know about heightened risk amongst people from poorer backgrounds. But again, no evidence of differential effect. So as I mentioned, Daisy's survey nicely collects data on depression and anxiety as well as some of the stresses that people feel in England. And top left, you see trends in depression and anxiety across time, again, in the period after lockdown, and if anything, evidence that levels of depression and anxiety have declined, but we don't know what they were just before lockdown. And in terms of the stressors, high levels of concern about COVID, about finances, unemployment at the time in the early weeks of lockdown, which have subsequently eased, but it gives you a sense of what's happening to population levels of concern. I think really useful survey, and if you're interested in reading more of these surveys are published on the web every week, the latest updates. In Bristol, we've concerned about the lack of sort of pre-lockdown data, we thought it would be interesting to look at Google searching as an alternative method of public health surveillance. So led by my colleague Dean Knipe in Bristol, we've looked at relative search volumes for terms indicating mental health distress, and she's written this up and published it in Welcome Open Research. But the lines here, again, track over weekly periods, this time from the beginning of the year, from the 1st of January, up until sometime in early July. And the red line at the top is trends on Google searching for anxiety. The green line at the bottom are trends in Google searching for suicide. And self-harm are the orange crosses, somewhere in the middle there. I think things I take from this are there's no obvious evidence of a rise in searching for suicide or for self-harm, some fluctuations. The most striking thing, I think, perhaps, is the peak in searching around suicide a couple of weeks before the first UK death from coronavirus. And interestingly, that corresponded with the death of Caroline Flack, a very well-known personality in the UK. And that prompted a lot of people looking up suicide, reading about the story online. So that's the extent of what we know so far about the impact of the pandemic. And I think the next few months will yield a lot more clear information about this as nations begin to report early suicide data. What should we be doing about prevention? So I've stratified thinking about this into two broad areas. And I suspect much of this will be familiar to many of you. Important things from a public health, population health perspective are carrying out surveillance to identify emerging issues at an early stage so we can respond to those issues. Putting in place economic safety nets to protect people who are out of work. Doing the sorts of things that nations who responded better to the 2008 recession did to mitigate the impact on suicide rates. Working with the media on their reporting of suicide-related impacts of the pandemic. Safe reporting. Carefully thinking about the risk-benefit balance of measures such as school closure. And of course, that risk-benefit balance will change as the incidence of COVID-19 declines, the risks of transmission will be less, and the longer-term risks of mental health may be greater. So these are kind of risk-balance equations we need to be continually making as the pandemic evolves. Putting in place community support, especially for people who are living alone or self-isolating, support for people who are bereaved by COVID-19, and ensuring services for people suffering from domestic abuse remain open. From a more clinical perspective, as I've already mentioned, it's really important we adapt our care pathways, online and video assessments. I suspect many of you now are very familiar with doing online assessments and the challenges and advantages they bring. We need to develop and better disseminate digital resources. This period has been a real spur to developments in this area. Making sure our workforce are trained to work in these new ways and expand the workforce appropriately if we can. Maintain and extend our crisis services and call lines and ensure routes to access to them are well publicised. We need to look after our frontline staff, of course, and support survivors of COVID-19 infection. There are concerns about long-term neuropsychiatric sequelae. And most important behind all of this is sufficient government funding for these sorts of initiatives. I'm aware of time, so I'm going to skip over my last few slides that summarise research priorities, but just flag up perhaps some sources for you. I've mentioned the international collaboration already. I'd recommend you go to our website, and there are links to the website on this page here. Any of you that are doing research studies related to COVID-19 and its impact on suicidal behaviour, it would be fantastic if you could register your studies on our study register. This has the dual effects, both of increasing the prominence of the work you do, giving you an opportunity to share your findings with others and identify potential collaborators for the work you're doing. Last time I looked, there are about 20 studies registered so far. Also on the website, there's a resource of possible questions to use in COVID-19 studies. So again, if you go to the website, if you think you're doing some work in this area, we've got some suggested questions that you might want to use in your studies. Just earlier this week, on Monday, we published an editorial in the journal Crisis outlining research priorities for the research community in this time. I'll put a link on this slide. Lots of tables of suggestions of areas which we hope will get covered in the research carried out in response to the pandemic. In Bristol, we're doing what we call a living literature review to try and identify all the newly emerging studies every day. Every day I have an update of the global evidence base. And so we can be kept in touch in real time with emerging evidence. The evidence base is expanding very quickly. Up until June, there were 2,000 studies that our search identified, of which about 28 were eligible and provided relevant data. And we just submitted for publication our first systematic review of that evidence. I'm going to skip over the last few slides. Important if you're doing research in this area not to compromise normal ethical standards. It's important that research complies with the normal ethical standards. It's important that research support is mobilised to ensure good quality research is in place, because we don't know whether if there might be a second wave. It's important we create a register of knowledge generated through the experience of the first wave of public health responses to COVID-19. And it's important that people carry out research who are appropriately trained. It's important we don't forget normal good practice in suicide research in the rush, if you like, to carry out research. So just to sum up, the short-term impact on suicide rates is unclear. There are concerns about the longer impact if there is a big recession subsequent to the pandemic. Short-term impacts are currently unclear. Some reassuring news from Japan, some perhaps slightly worrying signals from Nepal. It's likely that the impact will differ in different countries. There's evidence of reductions in hospital presentations for suicide attempts, but we're not sure whether that reduction is met by a real fall in incidence. It could be unmet need as a result of people not seeking appropriate mental health support in a time of crisis. The impacts of the pandemic, as I've said, will differ depending on the setting, the country, the characteristics of the individual themselves. It's really important that we carry out good quality surveillance to inform our prevention measures. We carry out good quality research and that it's ethically conducted in a time when carrying out research is difficult. And we put in place economic measures to mitigate recession effects. Okay, I think I'll stop there. Thank you for your attention. And I'm sorry to have rushed somewhat through those last couple of slides. I'm really happy to take questions if that's appropriate.
Thank you very much, David, for really an up-to-date kind of overview on not just, I suppose, the effect of COVID, but also considering the different cultural aspects of it. I'm going to open the discussion by introducing, we have our own, one of our national clinical programs. We have the clinical lead for the management of those people who at the moment, it sounds like in the UK at any rate, are not presenting to the emergency department. So Dr. Anne Jeffers is going to commence with a question. And I might just ask the audience if you're happy to allow us to extend by about 5 minutes, given that we have 2 speakers today. So we might aim to end at about a little bit closer to 20 to 2. Anne?
Thanks very much, Fiona, and thanks to both David and Pat for those great talks. Yeah, what we have found with the data in the clinical program, there was a marked reduction in presentations in March, but since then there's been a gradual increase, and that's despite the fact that many mental health services have been trying to divert people from the EDs and encouraging them to attend mental health services directly. So compared with 2018 and 2019, I believe we're going to see an increase. And it's interesting, based on Pat's presentation, and I think you're right, Pat, that we have an obsession here and this idea that everybody ends up in the ED when they're feeling suicidal or in a mental health crisis. But I wonder, could each of you comment on that, the fact that we don't seem to have seen the same reduction in Ireland that you're describing, David, in the UK?
Thanks, Anne. It's a really good point. And it worries me actually presenting some of these early data because I think the picture may be, we're talking about the very early months here. And I think if you look across the UK, I've heard different pictures emerging from different centres. And of course, the reduction seen in hospital presentations per se isn't necessarily reassuring. It doesn't necessarily mean that the incidence is changing at all. It could be that people aren't seeking appropriate help for overdoses that might require treatment. So I think what's really important is we keep monitoring. We recognise that there are going to be differences between settings. It's interesting. I've heard Ella, I think, mention similar to what you've said, Anne, that the kind of falls we've seen in England aren't mirrored by the experience in Ireland. I'm interested to know, when you say rates have come back up again, whether they've come above pre-existing levels or not.
In a number of the cities, Dublin, that was most affected by COVID, there's certainly, I mean, in some centres, they're seeing twice as many as the same months, in April and June in 2018 and 2019. So certainly.
So I think it's really important to get those data out there and make people aware, because I think this early shock period may not be typical of the longer term. We don't, in our community, in the suicidal mental health community, what we don't want is for politicians and funders to have false reassurance, I think.
Yeah, yeah. And Pat, maybe would you comment? I think you're still on mute, are you?
To the emergency department, and obviously they were less afraid as time went on, and maybe the problems got more acute, so therefore they needed to go more. But in all of these matters, I think it's important to keep the data, but also to bear in mind that it should be cumulative, and it should be over a longer period, and you should be comparing with similar periods in the past. So I think it's probably too early to judge yet, but we should keep measuring, I think.
Yeah. And then while you're there, certainly that suggestion that we maybe divert our funding from charities to primary and secondary mental health services. Sometimes within our mental health services, we often feel that the charities are signposting, often increasing the numbers who are being referred to us. It's certainly something within the clinical program we've looked at. Our concern is too many people are presenting to the emergency department with suicidal ideation alone. They shouldn't need to go there. So have you any ideas on how we might start that process?
I suppose that there was a movie that was called If You Build It, They Will Come. And I think the more services are available, the more people will present to those services. And we used to say in the States that some people were jealous of social workers who were taking on people for therapy, but then other people would say the more people they took on, the more they'd refer on to psychiatrists. So I think that's a natural progression. The more at primary care level there is, often the more referrals there are. So that's something that has to be sort of managed, and I think at a certain degree of proportionality applied to that. I presume we just have to sort of reduce our own anxieties as a country around the issue and approach it pragmatically. I mean, the evidence shows that if you have good mental health services and you try to treat psychiatric illness, that the rate will come down. The evidence also shows very clearly that if you introduce safety measures on a society level, and we mentioned the paracetamol packaging, but also in other areas, when you guard off iconic locations, that actually decreases it as well. So some sort of management of the whole issue and to try and reduce our anxiety, I think, is the way forward.
All right. And David, maybe you'd have a comment as well, because I mean, in the UK also, you have a lot of charities that would feel they're doing a lot of work. They feel they're filling a gap. I think that services aren't meeting.
I hear that very strongly. I hear that there's a mismatch between what the early data are showing from, I say this again, hospital registers, and what the charities are feeling out there. So we just need good quality data from across the piece, really, on exactly what's happening. And of course, charities are struggling in other ways as well because of financial concerns and donor willingness to donate at this time. So I think they've got double issues. And of course, if people are unhappy about presenting to the emergency department, what they may be doing by default is going to the charitable sector and voluntary phone lines, and they often get referred to those in the UK statutory services, and that puts increasing demand on the service. I'm thinking often our voluntary helplines are run by more vulnerable people to COVID, and so it may be difficult for them to muster the same range of and the same number of volunteers. So there are a whole host of difficult problems, and I certainly wouldn't want people's take-home message from what I've just said to be, actually, there isn't an issue here. I think we're in this for a long run. And to add to what Patrick said about the kind of safety measures, the economic ones I think are really important. We need to keep saying to politicians, these are the kind of things you can do to put in place to protect perhaps kids who are leaving school into the workplace at a time when it's going to be really tough to find work. There is this potential signal from our child suicide data of concern there.
If I could just add that I think one of the biggest difficulties is the confusion between self-harm and suicidal ideation. And that really part of the difficulty is any mention of self-harm, whether it is cutting or scratching, seems to some people, whether it's the support organisations or teachers, to be linked with an immediate risk of suicide. And I guess that contributes to a huge number inappropriately attending EDs urgently and needing to be seen. And it also probably doesn't give confidence to the support, the charities, to be able to manage those children. I guess, David, one of the things from an epidemiological point of view, I was wondering if you had any ideas why, because if you look at the UCL data that you showed, there seemed to be a disconnect. The rates of self-harm, they're very, very variable in the younger kids compared to the older adults. But also there seemed to be a disconnect between anxiety and depression post-lockdown. Both depression and anxiety seem to be reducing, but the rates of self-harm continued at the same level as they had before. And what's your thinking about the huge increased rates of self-harm in young adolescents that's even extending to pre-pubertal kids now and extending to boys as well as to girls?
Gosh, how long have you got?
About 3 minutes.
There's a paper, I hate to refer you to academic papers, but we published a paper looking at trends in suicide rates in high-income countries, and what's been seen in the UK is also being seen in Australia, States. So I'm very concerned about rises in suicide death rates amongst youngsters, and there's a signal of concern dates back to around 2008. Lots of speculation about what might be underlying that rise. No strong evidence, actually, despite popular press attention, that it's to do with social media, although it does concern me the amount of, the increased use of social media is a potential concern. Perhaps, if anything, stronger evidence that it relates to inequalities between countries. The countries that experience the greatest rise are those with the highest levels of income inequality. Go back to the self-harm, suicide attempt issue. I personally don't like, my personal preference, I'm probably in the UK in a minority, the kind of all-embracing term of self-harm to cover the whole gamut from a suicide attempt that someone comes within a whisker of dying from, and cutting oneself, scratching oneself as a way of relieving difficult emotions and tensions. And I think conflating those, whilst there's an awful lot of overlap, many people who will self-harm, self-injure will also make suicide attempts, and it's a risk factor for suicide attempts. I think there is a danger in conflating them, so I think we need to be clear in our terminology. So I'm of this kind of American school that prefers the terms suicide attempt and non-suicidal suicidal behaviour, not non-suicidal self-harm. But the kind of terminology in this field is fraught with challenge, I think.
But how do you explain the growing maladaptive coping mechanism that adolescents have by cutting themselves?
I think The honest answer is I don't know the reason. I think it is a behaviour. It's behaviour that children find useful in the short term for coping with difficult emotions. I think the more common it becomes, the more normalised it becomes as a way of coping. I think in societies, a number of societies have experienced dramatic rises in the use of this form of coping, as they have with other forms of coping during periods of time. So I think there's a danger of normalising it. Our work in Bristol shows amongst 16-year-olds, about 5-10 years ago, 1 in 5 at some point in self-harm has become a normal behaviour. And I think we need to help our young people develop alternative ways of coping with the difficult symptoms and their life difficulties that they're currently using it as a way of coping with.
There's a response, Pat, to your idea about Ireland being obsessed with suicide from Dr. Eamon Maloney. Does the suggesting that Ireland has an obsession with suicide have any basis in fact? In the same way, it could be argued that Ireland had an obsession with cancer or child abuse. And Eamon's opinion is that there's widespread genuine concern about suicide and self-harm, especially indeed as it does affect young people. So no smoke without fire, no fire, whatever that expression is.
I just want to say hello to Eamon, and we've had some vigorous debates before. It's a question of interpretation, really. It did seem like an obsession at one point, there 5, 6, 7 years ago, probably coming out of the recession, in that you couldn't read a newspaper without a big headline emblazoned about suicide, and incorrect type of media hype as well, which is regarded as unhelpful. But Eamon doesn't think that we have an obsession with it. That's his opinion.
Eamon, would you like to respond to that? If you unmute at the bottom left. Yeah.
I think the danger is, as psychiatrists, our view, our perspective is obviously totally skewed. So I think ascribing an obsession to a population is necessarily so biased, because we deal with suicidal behaviour and people with suicidal behaviour all the time. So what may seem like an obsession to us is in fact not. It is only because of our perspective as psychiatrists.
Anne?
I think, Eamon, that we have a bit of an obsession with both suicide and mental health awareness here, without necessarily putting in the proper responses. So, I mean, certainly we see it in the ED, that so many people are getting the message that the ED is the place to go to if you have any suicidal or self-harm ideas. And as we know, we are not always in a position to respond. So I think maybe the obsession is, and other people other than psychiatrists will say it to you, this mental health awareness is everywhere. Talk about it, go for help. And yet we're not getting any extra resources in either primary or secondary mental health services. So I think it's worth maybe thinking about that a bit more. And I really liked Pat's suggestion that, we really look at where the funding from NOSP and HSE is going, and make sure that we have a whole system approach to it, rather than charities on their own.
I would just be concerned that our responses, particularly to young people's youth mental health, hasn't been great. I mean, our traditional psychiatric services maybe aren't as open and as, if you like, as user-friendly as one would want.
Accessible, yeah.
And sometimes other organisations apart from the HSE or NHS are able to provide more user-friendly services, particularly for that population. That's the only caveat I'd have, but I agree. There's no point in a plethora of suicide prevention organisations. There could be a more coherent sort of approach to it.
I think sharing the vision, if we ever get it funded the way we'd like to see it funded, might have some of the answers, and that they talk about working closely, having close liaison between voluntary agencies and statutory agencies, which I think they're better at in England, David, that your statutory organisations work well with the third sector, as they call it?
Very good at referring people onto the third sector.
Oh, right.
So the Samaritans got a very high profile, and they take a lot of, their name appears on a lot of ED discharge summaries. NHS 111, the telephone NHS helpline recommends them. Just in terms of the debate we're having at the moment, I think there's a real challenge between the kind of high profile given to suicide and the real importance of raising public awareness and education about warning signals and when it's appropriate to seek help. So on the one hand, awareness raising is a really good thing, but there's a danger at the same time of normalization, I think. I think, to an extent, the stigma surrounding suicide may help stop people making that step. People who are experiencing suicidal thoughts make that difficult step towards making a suicide attempt. So I think we tread a very difficult line in the mental health field between, if you like, appropriate stigmatization to make a behaviour less likely to occur, but also at the same time raising awareness so people can appropriately seek help.
So regretfully, I'm going to have to bring our session to a close. I know that actually it would be lovely to have a more frank discussion about this. I think it really reminds us of the importance of real life data, because even if our support services were to collect data by way of how their numbers have changed post-COVID, you could compare that with what we see in the ED and in CAMHS and AMHS services. And to be a little bit clearer, David, about that distinction between suicidality and serious threat of wanting to end your life versus a, albeit maladaptive coping strategy that many youth have engaged in, and indeed, as you say, the impulsivity of ADHD cases by way of engaging in it. So regretfully, we don't have that data in Ireland, and you have it better in the UK. Bristol are doing a great job with the real life data and with some of the other organisations or some of the other, I know you're aiming to have it nationally, but I understand it's not there yet. And maybe that's something as well in Ireland we will be looking towards. So that's back over to Anne in her department. Can I just end by thanking you all for attending and for allowing us to extend it into your Friday afternoon. I can't believe it's the bank holiday weekend, and I am going on holidays next week for 2 weeks. And I'm very worried because our next session is not at 12:30. So please put in your diary, it's at 3:30 next week. I'm particularly worried that I will forget. And it is by Professor Lawrence Fung, who's from Stanford University, and who's talking about neurodiversity and the impact of COVID. And David, it's very germane to what you were talking about, the higher rate among ASD and ADHD kids, because indeed we are finding anecdotally with both CAMHS and the emergency department that those young people are struggling particularly for all sorts of reasons as a result of COVID. So please do join us next week at 3:30. Can I wish everybody a really wonderful, sunny, as I look out the window, if you're chasing it, bank holiday weekend. And thank you very much for participating. And thank you both to David and Pat for a very stimulating discussion and talk. All the best, everybody.
Thank you.